Well, good morning, everyone. So I'll get to it because we have a lot to cover. You know, throughout my career, I've had the privilege to give many talks. And as I was going through my CV of the many hundreds of national, international talks, I looked at all the debates I had, and approximately 10% of my talks have been with had a format of debate. And you know, what makes a good debate is a good topic and speakers that are logical, know their topic, and so on and so forth. Just so that Julien knows who I've debated. I've debated Ken Maddox, the guru of trauma surgery. I've debated, that's internationally. I can name a few other internationals. More locally, I debated Tarek Razak. I debated Jean-Marc Troquet. All these people have one thing in common, very logical, and they don't know their stuff. So hopefully Julien can meet those standards. So I start off with this picture. This is Einstein debating Oppenheimer and Teller and so on and so forth about the theory of relativity. I just want you to keep this picture in mind, and I'll come back to it later. But look at the look of that Einstein has, and keep that in mind. So. On my debates, whenever it's not virtual, I always bring a few things for my competitor. I bring a towel because I know that they'll be sweating. I always bring a bottle of water for them with their trial of rebuttal of my incredible logic. They're going to be dry, so I always give them bottles. I definitely bring a box of Kleenex, but I think at this time we'll do a little bit more than that, and hopefully Julien has that. So I think we could stop the debate right now. I don't know if you guys looked at this yesterday, came out yesterday. I think we could stop the debate right here. But for those of you that didn't have a chance to look at the latest editorial from the NEJM. Anyways, we'll come back to this later. So the title of the talk is that. Without it giving a little bit of a format and sort of structure to the debate so it doesn't disintegrate into something really bad, the plan is going to be I'm going to present my spiel, followed by Julien presenting his spiel, and there'll be a few minutes rebuttal on my end and his end, and then we'll open it up to Q&A. So that's the format. That speaks for itself. So let's start off with what I'm going to be debating about, that ACLS has an incredibly important role in traumatic cardiac arrest. Granted, I think to start off with, we have to acknowledge what is obvious. The levels of evidence for ACLS is not is such that it's very limited as far as good level of evidence. As you can see, level of evidence A is only 1%. And just to give you guys a little bit of background, what that means, level A is high quality meta-analyses and more than one RCT. So we acknowledge, and I acknowledge that evidence for ACLS in cardiac arrest and traumatic cardiac arrest is not very good. And as such, we rely on, for the majority, level of evidence C, which is either limited data, and more importantly, expert opinion. And this is where I come in. So you will, at the course of the next few minutes, when my dear colleague comes on, he's going to try to sell you some snake oil, and he's going to go on his soapbox and try to argue for snake oil level of evidence for what he deems as potential things you can do in traumatic cardiac arrest. But I warn you that even with ACLS, the level of evidence is fairly poor, and what he's going to present is even going to be poorer. So keep that in mind. So once again, we rely on expert opinion more or less. And just to remind my dear young colleague of sort of who he's debating, and most of you know. So I've been at the MUHC, dividing my time between the children's and the general for the past over 20 years. I've done rural emergency medicine as well, so you can't say that I don't have experience in that. And I've had a 1-year stint at the the finer institutions of our country, UHN, sick kids, so on and so forth. So there's some expert opinion behind what I'm going to say. So for the remaining 12 minutes, these will be my goals. I will highlight proven ACLS accepted interventions which have positive impact on outcome, and then try to prove to you guys that there are severe limitations in diagnosing traumatic cardiac arrest and the potential negative impacts that any sort of intervention that my dear young colleague would bring up can have. I want to make this as interactive as possible, but obviously time limits this. And if I were to put my dear young colleague on the spot and ask him, can you define what traumatic cardiac arrest is? I think he'd have trouble. In fact, if you Google traumatic cardiac arrest, you'll get something nonsensical that says cardiac arrest caused by trauma. But I've developed a definition that I think makes perfect sense. It's cardiovascular collapse secondary to injury caused by IV depletion, mechanical disorder, and neurodisconnect. Really, that's what it is. And this leads to a terminal rhythm of either too fast, whether it be VF, very rarely VT and PEA, too slow, which is probably pre-arrest and the end of the story, and or asystole. So getting back to the topic of this talk, let's look at the Grim Reaper's favorite toys using ACLS. Keeping in mind what ACLS is really. It's basic management of airway, relieving upper airway obstruction, proper oxygenation, this is BLS, chest compression, electricity, IV fluids, medication, and quote unquote procedures. And I put procedures in brackets because it's a needle decompression and quote unquote pericardiocentesis, both of which have limited role in traumatic cardiac arrest. What my colleague will try to convince you of is the procedures are the most important thing in traumatic cardiac arrest, and the rest is BS. So do we have a good evidence for the airway oxygenation? Absolutely. Chest compression? Absolutely. Early defibrillation? Absolutely. Proper use of an appropriate use of IV fluids? Absolutely. And like I said, in the very limited type of situation, these quote unquote procedures, but in traumatic cardiac arrest, less likely. Medication, I will tell you that, as we know, has limited role and with very little good evidence. If I were to pick a slide that's the most important in a talk, and I think that's very important, that a speaker talks about the most important slide in the talk, I would say this is it. This gives you the first monitored cardiac rhythm and the cause of traumatic arrest. And we see the causes, the main causes of traumatic cardiac arrest are down here. And then we see that the prevailing rhythm that we see here. I will get rid of the unknown because we have no idea what that means. So I took off the unknown. So we're left with these causes of traumatic cardiac arrest with the rhythms. I highlighted the ACLS interventions that I've listed, that is IV fluids, airway, so basic BLS, compression. All of these have proven benefit to these types of rhythms. I will get rid of asystole because asystole is asystole. And let's just talk about potential reversible causes. And notice that just basic, without even procedures, basic, so BLS and proven ACLS interventions have a role in all of these causes of traumatic cardiac arrest. I'm not quite sure if my learned young colleague is even aware that very recently, AHA came out with their recent updates for their 2020 guidelines for ACLS. And if you look through the algorithm, the basic structure is really BLS, chest compressions, defibrillation. And only later on do treat reversible causes even enter into the scene. And most of these reversible causes are medical causes. Very few, tension pneumothorax and tamponade, even fare into this, but the whole idea of this slide is just to prove that the basic structure of resuscitating someone, whether it's traumatic or not, is ACLS guidelines. So once again, IV depletion, mechanical disorder, neurodisconnect leading to arrest, causing dysterminal rhythm. And really, the only way an ACLS is there for all of these, as far as treatment guidelines, the only place where potentially interventions, quote unquote, come in is in the context of too fast PEA, and there's a mechanical disorder, such as intention pneumothorax and or pericardial tamponade. And once again, pericardial tamponade being the cause of traumatic cardiac arrest is fairly low. I will very briefly touch on pediatrics. My dear young colleague will not be happy with this either. PALS tells us that really kids die, whether it's medical or traumatic, basically two things, hypoxia and empty tank. And both of these PALS, if you look at follow basic PALS guidelines, ascribes to treating basic life support, oxygenation, ventilation, and IV fluids. Priorities are defibrillation, oxygenation, ventilation together with external compression. Let's quickly reboot. Levels of evidence in ACLS, fairly poor, but better than with traumatic cardiac arrest, heroic measures. You need experience to be able to manage these guidelines. We know that ACLS, if you apply ACLS principles, you'll treat most of these conditions, with the exception of what I've showed to you before. And we see that the cause of traumatic cardiac arrest and nocturnal rhythm is the same. What ACLS does, what it ascribes to, it is supported by the best evidence we have right now, and this applies to PALS pediatric population as well. With that, let's go on. I will very briefly touch on what Dr. Julien will be talking about. The Grim Reaper's favorite toys, no ACLS. Basically, he's going to be talking about interventions such as chest tube and opening the chest. We have to keep in mind that both of those interventions are appropriate in a very, very few selected cases, but things are not always as they seem. There are wolves in wolf skull closing as well. There are very many traumatic cardiac mimics. These are just to name a few that can look and sound like a wolf, but they're not a wolf. So basically, somebody gets hit in the chest and has a VFib arrest. Opening the chest is probably not going to be the best thing for somebody like that. What about electrical injury? Same thing applies. There's this very, not very rare, but fairly rare entity called impact brain apnea that many of us don't even recognize, where just basic life support and maybe some ACLS would help, but clearly not a chest tube scenario or opening the chest scenario. And of course, more and more we see primary cardiac medical arrests that could look like traumatic cardiac arrest. The single vehicle crash or the fall from own height who presents in cardiac arrest. And if you were to ascribe to the things that Julien will tell you, you would rush in with bilateral chest tubes and opening the chest, where that's not what's needed, but basic ACLS. Even the journals that ascribe to trauma highlight that to get out with brain intact, if you have advanced life support initiated at the scene and in the ED, you have very good outcome. Well, very good, pretty good outcome. This is not ROSC, right? This is coming out of the hospital with an IQ of 300. So even trauma literature ascribes to it. Here's another one, fairly recent. Cardiopulmonary resuscitation after traumatic cardiac arrest is not always futile, with the conclusions as you see. So getting back to Julien's heroic measures, there are also some dangers to it. First of all, how many open chests have we done that have been futile? It's worth reading this quote on futility. Very true. And we all agree that first, we do no harm. And to rush into potentially very invasive measures, we have some harm. Resource management, whether it be personnel resource management. To open a chest, you need a trauma team, you need nurses, ties down the emergency department. Even if you achieve ROSC, what does that mean? Patient will be in the intensive care unit, brain dead for how long? And that entails with it costs as well, and incredible resources as well. What about the personnel themselves who are participating in these heroic interventions? There's the potential bloodborne needle stick scalpel injuries that I've seen many, many times, with obvious potential for HIV, HEP, and so on and so forth, diseases transmitted. And then what about the PTSD that that personnel who undergo these incredibly invasive interventions suffer? And what about next of kin, friends, family, who might even witness these interventions, or who are subject to these things? They have trauma as well. So we have to keep these in mind. What about competence? I mean, I will say this is not very exact data, but I would say there are about 20 ED thoracotomies per year in our shop. That translates to 1 to 2 per month at the most. How competent does Dr. Julien feel about opening the chest and doing the right things? So when it comes down to it, basic life support and advanced cardiac life support is the way to go in traumatic cardiac arrest. And getting back to my scene, these are you guys. This is Julien, and Einstein's looking on saying, what a bunch of idiots. Not you guys, that is, but Julien trying to argue for the theory of relativity when it's already been solved. And with that, I end my talk.
Thanks, Joe. Thanks, Joe. I feel no pressure here, and I'll just start my presentation right now. Oh, not a good one. Can I get the access to share my screen?
Go for it now, because I took myself off.
Okay, great. Okay, thanks. So, Joe, for my part, the literature will talk, not my CV, and I'll try to convince you that basic CPR and resuscitation, it's not a good thing to do in traumatic cardiac arrest. So let's start here. There's 2 possibilities when we receive this patient. You can do basic CPR with the standard resuscitation, or you can place your patient in a cruciform position and try to reverse the causes of the traumatic cardiac arrest. Let's talk about Patel Physiology here, and I think it's important to do. We always talk about resuscitation and maneuver for the resuscitation of patient with cardiac cause, but let's be honest, it's not the same thing. You have a fully heart full of blood on the left side. You're doing CPR, you try to increase the cerebral perfusion, coronary perfusion, try to increase the chance of going in ROSC. But if you have the same case in traumatic cardiac arrest, you pumping a dry heart, the initial rhythm is not the same, and it differs significantly from the standard cardiac arrest that we see. Let's back in the 80s to talk about chest compression. Famous study done by Maddox showed that if you have a truncal trauma and you do external cardiac compression CPR for more than 3 minutes without any intervention, survival rate will be 0%. And after this study, a couple of surgeons tried to understand what's going on with the cardiac massage and with traumatic cardiac arrest. They put 3 baboons in shock and stabbed the aorta, and try to see what's going on when we do a cardiac compression in a severe hypovolemic shock. They found that it's probably harmful to do CPR because the coronary perfusion will be even lower, and we can cause extra injury during compression. So it's sure that with 3 baboos, I cannot say to you that CPR is harmful, but for sure, I cannot say that it will help your patient here. And let's talk about epinephrine, like why we give epinephrine traumatic cardiac arrest as we do for standard resuscitation. A retrospective analysis of a large cohort showed that if we just doing a CPR with standard dose of epinephrine, it's a poor marker of survival rate, and it's probably harmful for your patient. So let's be honest, the chance of success here, if we do standard management with chest compression and epinephrine, is very, very low, and we're not treating anything. So Dr. Nemeth tried to present you a couple of old evidence before 2015, like 2006, 2013, but the game changed around 2015 with all of the new studies. So a big statement from European Resuscitation Council guidelines said that in cardiac arrest caused by hypovolemia, cardiac tamponade, tension pneumo, chest compression are unlikely to be effective as normal volemic cardiac arrest. So after this guideline, the management changed for treating traumatic cardiac arrest. And I just want to point you that, you know, some of our colleagues stay in mind that doing resuscitation for traumatic cardiac arrest is futile, and the survival rate is still 0%, as Maddox told us in the 80s. But the latest study, we show around a survival rate of 8%. This is just one of the study, but if you check the literature, many of the study will arrive at the survival rate around 8% for a majority of patients with blunt trauma. So the conclusion of this particular study say early and aggressive management of patients with TCA using protocol that target the reversible causes should be initiated, and the reversible causes will be the second part of the presentation. A big literature review done in 2015 by Smith try to say what are the causes of the traumatic cardiac arrest and what we can do to treat the cardiac arrest, the traumatic cardiac arrest. And it's about the same that the presentation of Dr. Nemeth about why patients die in traumatic cardiac arrest. So there's hypoxia, of course, oxygenation, intubation, or a King LT in place, combative. If it's going well, we just we'll let it go. We'll let the King LT or combative in place. Hypovolemia, I will not talk a lot about this, but you because it's pretty standard as treatment. You just start your massive blood transfusion protocol, and the two things that I want to discuss is the tension pneumo. We will need to do a bilateral chest decompression. And at this point, I want to picture yourself doing a standard resuscitation with an ongoing CPR and try to do a bilateral chest decompression. And then the next move will be, do we need to do a thoracotomy? And it doesn't make sense for me to do an ongoing CPR and try to reverse all these causes with an ongoing CPR, and the final move will be, do we need to do a cardiac tamponade? So just to put a little bit of structure, a great talker about this subject, a certain Dr. Joe Nemeth, did an emergency medicine cases a couple of years ago, summarizing all these causes, and introduced the Memonic HOT. So you need to think HOT, hemorrhage. Let's start massive blood transfusion, oxygenation. As I said, you just ventilate your patient, tension pneumo, bilateral decompression, and the last T for tamponade. Chest decompression, why we do this? Very small study. I just want to present you because 37 cases is probably the number of patient traumatic cardiac arrest you will see in your career. Maybe more if you're working only in a tertiary traumatic center, but in this study, 37 cases of traumatic cardiac arrest, 18 chest decompression, and on the 18 patient just with the bilateral chest decompression, 4 at the return of cardiac output. So for a very simple intervention. How we do this? Is it by needle decompression? So first study I present about this is a study done by Kenji Naba in California about needle decompressions. So where we do this is it's on the anterior classic mid-clavicular, second intercostal space, or we going at the same place that we do a chest tube. So there's a very high failure rate if we are going in the mid-clavicular, like near 43%, because the chest is a little bit more thick at this place. And even with the needle decompression at the 4th and 5th intercostal space, there's still 17% of failure rates. So here, my take-home point is we need to do bilateral thoracostomy. If you have a full trauma team, you put your best on the left side. So CPR, there's no place. Just picture yourself, okay? You put your best player on the left side to do the thoracostomy on the left side, and then you will have the possibility of doing a thoracotomy. The junior can be on the right side, and you do thoracostomy. So full trauma team, you can put chest tube if you want. If you have more limited resource, finger thoracostomy is very good. And as we just saw, even if you do the needle decompression on the 4th and 5th intercostal space, the chance of failure is still high. So, and the needle decompression, you will fail to decompress the tension pneumo, and it's impossible to expulse hemothorax. So bilateral thoracostomy, finger thoracostomy is the intervention of choice. And after, we need to fight the last T, the tamponade. So here's the decision of doing thoracotomy, and as Dr. Nemeth said, it's a very stressful intervention, and my role here is trying to give you the best indication of doing this procedure in a good patient. So what the Western Trauma Association said about this is they're giving us a timeline, okay? So blunt trauma patient, maybe we have 10 minutes to act. The best chance if we get these patients penetrating torsal patient, you will have the best chance of success. And the other one you can read, but sometimes it's a different setting. So just 10 minutes for blunt trauma and 15 minutes for penetrating trauma. So how we can choose wisely the patient that we will perform thoracotomy. So another study done by Kenji Naba in the LA County, very nice study for us guy in emergency, because he tried to, so he include 187 patients. He did a fast and a thoracotomy. And a fast was considered positive if there was some cardiac motion or pericardial fluid. In this study, if the patient has a chest thoracic penetrating trauma and a positive fast, they were excluded of the study and went straight to the OR. So of course, if you have this scenario, you need to act and do the thoracotomy. And what the study said is, if you don't have any cardiac motion or no pericardial fluid, the negative predictive value is 100%. So, I mean, it's not absolute, it's just one study, but for sure it can help you to choose wisely the patient that need to add a thoracotomy in the emergency department. And so here's the picture that you will see if you do a left thoracotomy. And as an emergency physician, like the most important thing to do is decompress the pericardium. So very simple, you take a creel, you just do a separation between the heart and the pericardium, and with you do a small incision with a scissor, and after you just take your finger, it's non-traumatic, and you will relieve the tamponade. And after, if you want to do a cross clamp of the aorta, and we're not a surgeon here, you just put your hand between the aorta and the column. You don't have to do any dissection, and it's gonna work well. If you see a big bleeding, honestly, my take-home point, you just put your finger on it, or you put a Foley if there's a wound, and you wait for backup. So in conclusion, there's a high failure rate with standard treatment. you don't need to, I mean, you don't underestimate an ongoing CPR with this resuscitation, because I cannot say with the evidence that CPR it's totally harmful. Direct CPR is harmful, but what I can say is CPR is harmful because you will waste time doing the reversible causes and the technique to treat traumatic cardiac arrest. And finally, think hot and reverse all the causes. Thanks.
So I'd like to quickly rebut a few things, and then we can. I don't think Julien can rebut anything of mine, but I would like to rebut some of his stuff, and then we can open up for question and answers. So Julien, first of all, I mean, where do I start? But it's going to be very quick. So first of all, you use literature very inappropriately. You talk of me using old evidence. You brought up the Maddox and the Luna paper, which are like over 30 years old. Number one. Number two, you use literature, but completely inappropriately in that it has nothing to do with the talk. You bring up the Inaba paper where ultrasound is used to prognosticate when we can stop the resuscitation. The patient has poor prognosis, has nothing to do with ACLS. Also, I recorded it, 8% of the time of your talk on procedure of how to do a thoracotomy. That was not the goal of this debate. Also, it's a classic error in somebody who doesn't know how to debate, that you use straw man arguments. Straw man, look it up. I'm not going to describe it. But basically, first of all, you talk about epinephrine, which I completely agree with. And I even said medications have very little evidence on. So don't even bring that up. The other straw man you used was using decompression at mid-clavicular line. That's old news. We knew that before. I never advocated for that. And I can go on and on. Bottom line is that, and then my last one, the one that used that there's a guy named Joe Nemeth. Actually, there's two Joe Nemeths. You didn't do your work well. He's an emergency doc from Kazakhstan, and he's the one that gave the EM cases talk, not me. You should have done your homework better. So, and then you didn't even talk about competence. You didn't talk about the traumatic cardiac mimics and the harm, so on and so forth. So basically, that's my rebuttal to you. Do you have any rebuttal to me? And then we can open it up seriously for some QA very quickly.
No, sure. So let's review your points. I decided to present the Maddox and the old study because with the limited knowledge that we had about traumatic cardiac arrest in this year, that's explained why we failed, is because we blindly applied ACLS protocol and standard resuscitation, and patient died. So that's what happened, and that's what Maddox proved with his study. Doing the thoracotomy, it's still an important part that we need to consider in the ED department, and I think that we can reverse and do a big difference here. And as you said, I try to present evidence that we need to choose wisely the patient here, because some of us will not work with all the trauma team and surgeon in place. So we can try to focus on a good patient and doing the good procedure at the right time. And this is one of the of my message here. And I hope that bilateral chest decompression is a take-home point here. We need to blindly do the chest decompression here. And I'm not talking about taking time of doing EFAST, and maybe there's a slide, maybe not. It's a bilateral thoracostomy, and this is a very, very high important intervention that we need to do.
Okay, so anyways, excellent. So first of all, thanks guys for bearing with us. When all is said and done, you guys probably know where I stand, but you know what? I recommend that you go through this exercise where you're opposed to any view, whether it be medical or what have you, and try to argue the opposite view, because it definitely opens your eyes to the whole picture. And I think that makes us better educators and professionals and so on and so forth. So clearly, I don't advocate for, or I advocate for what Julien said. Traumatic cardiac arrest is a different beast, and I'm not going to get into the details. Julien expounded on it already. ACLS has limited value even in medical arrest, although, you know, but for traumatic cardiac arrest, you know, very, very limited value, if any. And the only thing I would highlight is be careful of the mimics, especially primary medical arrests. because more and more people are living with a lot of comorbidities. Even young people can come in with, with seeming, traumatic cardiac arrest, and they have something underlying. So just keep that in mind. Contextualize the whole presentation. Patient comes in with a fender bender from the parking lot. Very likely that this patient is not having tension pneumothoraces, So that's my only thing to highlight here. Julien, I hope you didn't take anything personally, as you know, it's just to make things interesting. Any questions or comments?
I want to salute Julien's courage.
Thanks.
No, but seriously, any comments on this? Because it still comes up when you guys rotate through the general, and I talk to you about how we're going to deal with somebody with traumatic cardiac arrest, and I still see some eyebrows lifting up that's saying, that, wow, we're not going to do chest compressions initially, and so on and so forth. So, I mean, if you have questions, please. I think Francois is on board too. I think that's the only other TTL I have, or even other people who have other strong views on either way. I think this is the time to address it.
Joe, can I just, go ahead, sorry.
Sorry, so Monica. So hi from the other part of the world. So this is Aziz, I'm saying hi for everybody. So I have a question. I had a case when a trauma fall from height, but she had a VFib arrest when she came on the monitor. How would you deal with that?
She had what, VFib?
Yes. Yes, not asystole, a VFib, but she fell and she have a clear trauma, like clear open book pelvis and everything, but she had a VFib on the monitor. So I was stunned a little bit. So I did both, as Monica says. So I did ACLS and I tried to do like chest tubes and bilateral thoracotomy. Yeah. So how would you approach this?
Interesting case. I have yet to see, I mean, maybe because we don't put the patient on monitor when they come in and arrest. By the time the patient gets on a monitor, it's a long time. So it's hard to know whether we were missing them. Before I answer the question, first of all, hi Aziz, nice to see you. Really, it's nice that you participate. It's really nice to hear. And it's nice to quote unquote see you. And that's number one. Number two is, before I answer, I will let my dear young colleague give it a shot and see what he thinks about this this scenario. How would you deal with if somebody comes in VFib and a truly traumatic cardiac arrest? Like Aziz, this patient fell from like what, 20, 30 feet or what? Yeah. Anyways, I'm
something around that. Sorry.
Yeah. So like, it's not like fall from own height. Yeah. So how would you deal with that? Would you defib? Would you put chest tubes? What would you do?
I mean, I think that with the clear VFib, it's fair to try defibrillation here and try to start the standard procedure that we discussed with the massive blood transfusion protocol and oxygenation. We can give a shot to defibrillation. If works, that's good. If not, we just continue with the other intervention. That's my answer.
Francois, do you have any others? Do you have any other? Would you do anything different? I don't know if he's there. Or
yeah, I'm there. I kind of missed the beginning because I'm fixing myself a coffee, if you want to know, but worked last night. No, well, in a case like that, you can also, if clearly there's a major mechanism, you can proceed with your thoracotomy and prepare your internal defib pad. A lot of time as well, I've seen this not on the monitor, but I've seen, a heart in VFib once you're actually in the chest. And there's two things that I've seen. Either I've seen the pads being used successfully, or when you start like actually the internal massage, the VFib stops, and then you go back in PA. So I've seen both of these cases happen.
Aziz, did your patient make it with you doing things in parallel?
No, unfortunately, she didn't.
Okay. Ken had a question about I'm assuming the question is, would we apply ACLS in blunt versus penetrating, or would you have any difference in the sort of the whole paradigm of approaching? No, my answer is no. If it's a true legit, so it's not a potential, like in blunt trauma, it's not a potential medical cause of arrest. For me, it doesn't change anything as far as ACLS principles I would continue with the classic TCA protocol of relieving potential bilateral tension pneumothoraces, starting blood, and so on and so forth.
Joe, my question is more from a practical standpoint. So you know that it takes time for us to set up for most things, right? You never manage to have what you need to do your finger thoracostomies or your thoracotomy or anything else for that matter set up and ready to go most of the time. So there's a window of opportunity. Is there a reason, if the mechanism and the patient's presentation is not immediately suggestive of massive exsanguination or obvious hemorrhagic shock, to start with compressions and get a monitor on there and see if there's something that's potentially amenable to electricity? Your FAST is the one thing that's available to you right away because the machine is always on. It's at the bedside. And while you're getting everything else set up, you're doing a quick EFAST to look for evidence of severe hemorrhage in any body compartment if it's not already on the floor. And if you don't see it, what is the harm to continuing with your compressions and or defibrillation if indicated while you wait to set up for those other traumatic procedures? Is there a harm? It may not work, but is there a potential harm?
I'll give you the short answer and I'll give you a bit of a longer answer after. The short answer is harm. The only harm is that you have certain limited resources, whether that be, well, mainly personnel resources, and you're using those personnel sources, I would say inappropriately, before using those resources to reverse potentially reversible causes. So that's my one-liner regarding your main question, is there harm? The longer answer is the following. I would argue that, yes, you're right. A lot of situations, patient comes in de novo with no warning. But I would say we usually have at least a minute or two of warning. But even if we don't, it takes 2 seconds to grab a scalpel. You don't need a chest tube. You don't need anything else. And make 2 holes in each side, so 1 hole in each side of the chest, number one. Number two, using ultrasound, completely in agreement with it. I just wonder, in the whole hustle and bustle of things, how sensitive your ultrasound findings will be, specifically your EFAS will be. And you can maybe quickly rule out pneumothorax. However, hemothorax, it might take a little bit longer, and so that's my one-liner on that. 100% I would use it, but more so I would have somebody looking at the heart more than anything else. And then as far as if you really are looking around for a scalpel that you know yourself you can get in 2 seconds if you know where your shot, where things are, is there any harm to start CPR? I mean, I guess not, but all I'm saying is I'd be worried about taking precious resources, personnel resources away from things that we could be doing, which is proper back valve, ventilation, and and making sure that there's no mechanical cause of cardiovascular compromise, and of course, getting blood on board.
I mean, I am, just to answer Monica, as you know, Monica, I'm very pro CPR, but I think no one knows for sure because this is obviously not studied, but there's a theoretical concern of making an injury worse. If you have a cardiac injury, a traumatic cardiac injury, or major intrathoracic vessel injury, increasing thoracic pressure and compressing these organs, this is really not what CPR was invented for and designed for. So there is a theoretical risk to make any injury that potentially by access, direct access and clamping and whatever you're going to do are potentially reversible. And again, in selected patient, when you do a thoracotomy, like most of the series will show a survival around 22%, which is not trivial. It's actually much higher than non-traumatic cardiac arrest. Again, in the appropriate setting, in a tertiary center, when there's at least a minimal amount of those procedures being done routinely by teams that are familiar with these procedures. But it's still amazing. And even at the MGH, the last time, I don't know, maybe Joe knows the number by heart, but it was around 20% the last time this was looked in our own setting, especially for penetrating trauma. So again, there's the potential arm of delaying the ultimate procedure. There's the theoretical concern of making an injury worse. And yeah, third, there's the potential use of resources not where the money is. So I think it's one thing to say we're going to try one shock because I'm already on a monitor and I'm ready to shock. To do compression is a bigger decision because there's a potential concern to make actually the situation worse, as opposed to just giving a shock and then entering the chest.
So then would you say, would you say then that it's reasonable if we are called, let's say we get a call, whatever, traumatic arrest comes in, we'll say it's obviously a fairly significant trauma that could potentially be the cause of the arrest, that we have our scalpels ready, that we have the probe gelled up with a quick subxiphoid view and or others as we see fit. I'm assuming this is not a penetrating, right? So I'm assuming this is a blunt traumatic arrest, that while you're getting everything set up to invade both thoracic cavities, you do a quick look of the heart. If the heart has no activity, there's no pericardial fluid, do you ascribe to Kenji's thought process that at that point you should just stop? Or at that point, would you consider traditional ACLS, thinking that perhaps the arrest is related to something else?
Joe, you want to answer that? Or
actually, Philip's on. I'd like for Philip also to weigh in on what he thinks about this one. Phil?
Hi, yeah, I'm here. First, hi Aziz, you look very good. Secondly, I think that the whole question of what we should do in terms of ACLS and ATLS, as Monica said, are not mutually exclusive. That being said, the harm that could be created for aligning a team towards doing compressions, putting pads on, and having epi drawn up is diverting resources from very simple things, as you said. And so what was the last question? So should we, if something?
No, do you risk prognosticate using Kenji's paper about patient with penetrating or blunt comes in, akinetic POCUS and nothing in the pericardium? Would you call it there? Or Monica's asking, would you start ACLS paradigm, or would you continue with trauma paradigm, meaning cross clamp aorta, fill up with blood and close open cardiac massage?
I think that the paper is very good and very convincing. I think that if you stop there, I wouldn't start ACLS at that point.
What about the other things?
So cross clamping, it always depends. So I don't remember if there was a distinction for thoracic, extrathoracic, or blunt.
No, but in just general, forget about that paper, but would you cross clamp, fill up, like pour in massive blood and start open cardiac massage in somebody in asystole like that, or would you just call it? I guess that's the question.
Oh, I think it's convincing enough that I would stop. And if you stop, you don't open the chest. And if you don't open the chest, you don't go for those second and less efficacious measures, which are, intrathoracic massage or cross clamping or high leg twist or whatever. So I think if you do open the chest and you give it a good indication for that, your best bet is just relieving tamponade. That's the thing that works the best. And I was putting on the survival rates from the I think they're from the EASE guidelines. from the review of the literature, which is the last thing that was essential that they had. So it's pretty good for thoracic with signs of life. Other than that, it decreases depending on the setting.
Phil, you have to make your bed first. Second, yeah, I would, you know, to answer, give my opinion on this, I would definitely call it and not, especially not do massive transfusion against precious resources. The only caveat to that is, you know, if you're unsure what happened and if there is a chance that you know, and I've done that before, if there's a chance that there's a medical arrest component, you can definitely run a short code, but I would not, you know, I think it was alluded a bit in the talk, again, all these procedures done in a rush, there's still a significant amount of needle stick and arm, so you want to do it with, you know, some minimal screening, and I think that paper, you know, even though it's a single paper, helps us really, at least, you know, it really changed our practice. We had some discussion on the TTL listserv, and I think we're way more selective. You won't see a lot of open chest being done for blunt traumas anymore at the MGH, unlike what it was like, you know, 10, 15 years ago. So I think we did change and we're way more selective. So I think we have to be mindful of the resources.
I think it's a tough question when you have uncertainty about the history. So we had a case recently where I worked else in Saint Jean where, you know, there was a guy, an old guy driving his car, and the car flipped in the ditch, but there was nothing else. So hope that, like, it was a good thing that it was suspected from the get-go that the patient might have had a medical cause underlying, but came in comatose and ended up with a massive hemorrhagic stroke that most probably caused the accident instead of the other way around. I think the discussion lies in those cases where you have no idea and you might go one other way and mistake yourself. But in those really clear-cut cases, I think it's settled.